Hello friends, welcome all of you to my channel, and today we will be talking about the anatomy of the breast. So first and foremost thing, that what is a breast? So breast is actually modified sweat gland. So breast is a modified sweat gland. Now let's talk about the extent of the breast. So the breast lies so it has two extent, I mean the horizontal extent and the vertical extent. So in the horizontal extent, it lies from the lateral border of the sternum. So this is a sternum. So this is a sternum, and breast lies from the lateral border of sternum to the mid axillary line. So this is a, let's suppose this is a mid axillary line. So the breast lies from the lateral border of sternum to the mid axillary line. Now what is the vertical extent? So breast lies from the second rib to sixth rib. So second rib to sixth rib is the vertical extent of the breast. So now let's talk about the parts of the breast. So breast has especially the nipple, that is the middle part, I mean the pinpoint part of the breast, and surrounding the nipple it has areola, and the areola contains the modified sweat gland and the sebaceous gland. So let's first talk about the nipple. So nipple is actually that part of the breast which contain the multiple ducts, and these are normally the milk secreting ducts. And so nipple basically contain the ducts. Those are almost 15 to 20 in number, and these are milk secreting ducts. And nipple lies especially in the fourth intercostal space in the mid clavicular line. So the level of the the nipple is fourth intercostal space, especially in the mid axillary line. And the special thing about nipple is that the nipple is erectile structures. So as nipple, whenever the child start to suck the breast of the mother, then the nipple gets erect, and it actually help the child to feed the milk. As I said you that this areola and the nipple both are in combinedly called nipple and areola complex. So the nipple and areola are combinedly called nipple and areola complex. The color of the both nipple and areola is somehow the brownish black in color, especially it is due to the presence of the melanin. So the areola and nipple are especially brownish black in color due to the deposition of the melanin, and which increases during the pregnancy. So the nipple and areola complex are especially brown to black in color, and this brown to black in color is due to melanin deposition, and the deposition increases during the pregnancy. So it increases during pregnancy. So just by watching the color of the nipple and areola, you can just tell that the mother is pregnant or not. So in the non-pregnant female and then pregnant female, the color can be differentiated very easily. As I already said you that the areola contain the modified sweat and sebaceous gland. So areola contain modified sweat and sebaceous gland. So this sweat and sebaceous gland basically produces especially the sebum. Sebum means there is oily secretion, and they actually keep the areola and the nipple moist. So they keep the areola and nipple moist. And another thing, these modified sweat and sebaceous gland get enlarged during the pregnancy. So they during pregnancy they enlarge, the modified sweat and sebaceous gland enlarge, and now they are also known as glands of Montgomery. So what is glands of Montgomery? So the sebum and the sebaceous gland and the sweat gland, when they enlarge during pregnancy, they are also known as glands of Montgomery. So we were basically talking about the structure of the breast tissue, and I already said you it has one structure, that is a nipple areola complex. So this is nipple, and this is let's suppose this is a areola, nipple areola complex. Another structure is the parenchyma of the breast. Another structure is the parenchyma of breast. And the third structure, so first structure is nipple areola complex. This is the first structure. The second structure is the parenchyma of the breast, and the third structure is the fatty tissue. So simply they are the fat. So let's talk about, so we already talked about the areola and the nipple. Now let's talk about the parenchyma of the breast. So let us talk about the parenchyma of the breast. So basically the breast contain the lobes. The breast parenchyma contains the lobes, and in a breast there are 15 to 20 lobes. There are 15 to 20 lobes. So what is a lobe? So you are seeing a structure. So this structure is in overall known as one lobe. So this is picture of one lobe. So so you are seeing this is one lobe, and such type of lobe are 15 to 20 in number in one breast. Such type of lobes are in 15 to 20 in number in the one breast. So let's talk about the different structure of a lobe. So see, starting from these structures, these glandular structures, so these glandular structures are basically known as acinus. These glandular structures are basically known as acinus, and in plural they are known as acini. And these are the structures where the milks are produced, So these are the structures where the milks are produced. So acinus are actually the milk secreting glands. These are the milk secreting glands. And the acini actually combine to form the duct. So this combined, so different acini combine to form a duct, and this duct is known as lactiferous duct. This duct is known as lactiferous duct. And actually 2 or 3 acini are combinedly known as a lobule. 2 or 3 acini are combinedly known as a lobule. So this is one lobule, this is a one lobule, and this is a one lobule. So it's actually let me tell in a very good way. So this is one lobule. Sorry, I said you all this is one lobule. No, actually these structures are acini. So this is one acini, acinus, and now this is one lobule. This is one lobule. So in a lobe, so as a whole this is a lobe. So in a lobe there are almost 20 to 40 lobules. So each lobe has 20 to 40 lobules. So such type of lobules are 20 to 40 in number, and they converge in a duct. They are known as, the duct is known as lactiferous duct. And every lobe, every lobe has a separate duct, and that separate duct opens into the nipple. That every duct separately opens into the nipple. So we can say that the amount of duct in the nipple is 15 to 20. That is the number of the lobes. So the number of lobe is the number of collecting ducts. Lactiferous duct is also known as collecting ducts, as they are collecting the milk, and these ducts open into the nipple, and in this way the anatomy is actually present. So see, let's revise once again. So there are the acinus. So these are acinus, which are the milk producing glands, and now acini converge to form a duct. So different acini converge to form a duct, and the duct ultimately opens into the nipple. So the whole structure is known as lobe, and in a breast there are such 15 to 20 lobes are present in one breast, and each lobe contains 20 to 40 lobules. So these are the lobules. So each breast contains 20 to 40 lobules. So I think you got my point, what I am trying to say. So let's again learn this. So this I said you, this is a nipple, this is the areola, and there are different lobes present. There are multiple lobes, I mean 15 to 20 lobes are present, which actually open at the nipple, So this, up to this, you know. So you learned about nipple areola complex, you learn about the parenchymal of the breast. So this is known as parenchyma of breast. And there are some fatty structures surrounding these parenchymal structures. So the third component is fatty tissue. So let me explain some clinical points. So if there is a carcinoma of the lobule, so this carcinoma is known as lobular carcinoma. If there is a dysplastic change seen in the lobule, is known as lobular carcinoma in situ. And if the problem is in the duct, that is the lactiferous duct, so this is known as ductal carcinoma. So if the cancer occur in the duct, is known as ductal carcinoma, and if there is a dysplastic change in the cells of the duct, known as ductal carcinoma in situ. So I think you got my point, that is the lobular carcinoma means the cancer arising in the lobules, and the ductal carcinoma means cancer arising in the ducts. Now let me explain one more thing, that the male breast lack lobules. The male breast lack lobules, as the male do not secrete the milk. So the male breast lack lobules. So only cancer that affect male, or the cancer that occur in male, is ductal carcinoma. The male will not actually have the lobular carcinoma, as the male lacks lobule. That is why the male will not or never develop the lobular carcinoma. The male will only develop the ductal carcinoma. But the females can develop the ductal or can develop the lobular. Also. So female has both duct and lobule. That's why they can develop the carcinoma of the duct as well as the lobules. But the male will only develop the cancer of the duct, not the lobules. Now see the effect of hormones. So we will see the effect of hormones. So basically, the hormone that is responsible for the growth of the duct and lobules are the estrogen and progesterone. So basically, the estrogen will cause the ductal proliferation. And the progesterone will ultimately cause the lobular, or you can say the lobular proliferation, or you can say the glandular proliferation. So the lobules are proliferated under the influence of progesterone, and the ducts are proliferated under the influence of estrogen. And basically the milk secretion in the lobule, so milk secretion is actually under the control of the prolactin. So prolactin is responsible for the secretion of milk in the the female breast. So let's talk about some inner anatomy of the breast. So from the surface to the deep, let's go to the breast and see what are the structures present in the breast. So these are basically the skin of the breast. So these are the skin, and under the skin there is the fascia known as superficial fascia. So in the blue color I have drawn a structures. So this is a superficial fascia. Now this superficial fascia has the two layer. The superficial fascia has a two layer. The anterior layer and the posterior layer. So in this red line I am showing you the anterior layer of the superficial fascia. So you can see the anterior layer of the superficial fascia. So this red color are showing the anterior layer of the superficial fascia, and this blue color is showing the posterior layer of superficial fascia. Now the anterior layer of superficial fascia is attached to the skin by a ligament at different places. So in red color I am showing the ligaments. So these are the ligaments, and these ligaments, so these are the ligaments. So these ligaments are actually connecting the skin and anterior superficial fascia. Anterior superficial fascia. So these ligaments are connecting the anterior superficial fascia and the skin, and these ligaments are known as ligament of Cooper. These anterior ligaments are known as ligament of Cooper. Now let's talk about some clinical aspect. So whenever a cancer invades this ligament of Cooper, so let's suppose if any cancer is arising here, and if this ligament of Cooper, let's first talk about the function of ligament of Cooper. So these actually ligament of Cooper attaches the superficial fascia to the skin of the breast. So it actually holds the breast in a certain position. So maintain the position of breast. So the Cooper ligament maintain the position of breast. But let us suppose from any cancer, if any cancer develops in the breast, and if it invades the Cooper ligament, if it's damaged the Cooper ligament, then the superficial fascia and skin cannot be held together, and in that condition the position of breast will be altered. So there will be saggy breast. So there will be saggy breast if there is a invasion of Cooper ligament of breast. So there will be alteration in the position of the breast. So the breast will be saggy. It will not be in its normal position. So that was the clinical part that we discussed. Now let's see where the breast rests. So the breast rests especially in the muscle known as pectoralis major muscle. So see, so this is the superficial fascia. So this is the superficial fascia, but this is the posterior layer of the superficial fascia. Now just beneath the superficial fascia there is a space. So there is, let's suppose this is a space, and this space is known as retromammary space. Retromammary space. Simply you should think that retro means behind, mammary means breast. So it is the space just behind the breast, and this space is normally present that contains the loose areolar tissue. So this space contains the loose areolar tissue and is present in the normal breast. But if the cancer is invasive, and if the cancer is the more malignant, it can obliterate this space. So in cancer of breast, there may be the obliteration of this space. So the retromammary space can be obliterated in case of the cancer. So this is an important point you have to know. Now just behind the behind the retromammary space there is a fascia known as pectoralis fascia. So this is a, let's suppose this is the fascia. This is known as pectoralis fascia. Pectoralis fascia. And this pectoralis fascia is basically also known as deep fascia. Deep fascia. So in the blue color you are watching the superficial fascia. So this is also superficial fascia. And in the black color you are seeing the pectoralis fascia or deep fascia. And just beneath the deep fascia we have a muscle known as pectoralis major muscle. So pectoralis major muscle. So this is a pectoralis major muscle, and beneath the pectoralis major muscle a smaller muscle pectoralis minor is also present. Pectoralis minor is also present, and just for the extent you can see that second, third, fourth, fifth, sixth. So the breast lies from the space second intercostal, the second rib to the sixth rib. So the breast lies from the second rib to the sixth rib, and I said you the clinical aspect that the the loose area. There is actually the structures, that is the superficial fascia, the deep fascia, the pectoralis major muscle, the minor muscle, and you can see now the ribs present from the second rib to sixth rib. And in some cancers, there is obliteration of the retromammary space, and whenever the cancer cell invades the pectoralis major muscle, the retromammary space is now obliterated. And in some cancer, there is invasion of the ligament of Cooper, then the breast will be saggy, and sometimes the invasion of the ligament of Cooper will ultimately cause the depression in the skin of the breast. So sometimes will also cause the depression in the skin, depression in skin of breast. So if you see a depression in the skin of the breast, you should suspect some carcinoma behind that. Now one more concept you have to take, that if any cancer is actually invading, if let us suppose this is the cancer, I mean, if it is invading the retromammary space and if it is invading the pectoralis major muscle, then in that time this mass, if invades the pectoralis major muscle, then in that time the mass is immovable. The mass is immovable. So you can say that the mass will be, or the lump or the mass will be fixed. So in what time the mass will be fixed? So the mass will be fixed or immovable if it invades pectoralis major muscle or the fascia. So if it invades the pectoralis major muscle or the fascia, the mass become immovable. You should learn one more thing, that this, let's suppose this is the the breast, and let's suppose this is the superficial fascia. This is a superficial fascia. So this is the anterior layer and this is the posterior layer. This is the posterior layer and this is the anterior layer. And now let's suppose this is a deep fascia. This is a deep fascia. So the deep fascia is actually has a defect in the region of axilla. So the deep fascia has a defect in the region of axilla. So deep fascia has a defect in region of axilla. The deep fascia has a defect in the region of axilla, and this defect or the foramen is also known as foramen of Langer. Foramen of Langer. And if there is a defect, it is so obvious that the breast tissue or the breast gland come as a part in the axilla via this foramen. So the breast gland in its outer part can enter this foramen. This foramen can enter this foramen, and if the breast tissue or the breast gland enter this foramen, so this looks like a tail of the breast. So this looks like the tail of breast that is present in the axilla. That is present in the axilla. So that is why this tail is also known as axillary tail of Spence. So this tail of the breast is known as axillary tail of Spence. So this is somehow anatomy that we have discussed up to now. So there is a one question. That is lymphatic drainage of the breast. It is the most asked question in the breast topic, either in the surgery or in the anatomy or any examination. So to understand the lymphatic drainage of the breast, let's understand that the breast are actually, so these are the two breasts. You can see this picture. So this I have shown, this is the diaphragm. So basically the breast can be divided into the 4 quadrants from the nipple region. So let's suppose from the nipple I am drawing an imaginary one vertical line and one horizontal line in the both breast, and in this way the breasts are divided into the 4 quadrants. So let's suppose this is the upper lateral quadrant, this upper medial quadrant, this is a lower medial quadrant, this is a lower lateral quadrant. Now before going to the lymphatic drainage of breast, there is one question, that in which quadrant the breast cancer can develop, or there is a more chance to develop cancer in which of the following quadrant. So simply any lump or any cancerous lesion will occur in that quadrant of the breast which contains the maximum tissue of the breast. So actually the upper lateral quadrant has the maximum tissue present in it, and the lower medial quadrant has the lowest tissue density in it. So if we take the overall breast quantity as 100%, then almost 60% of the breast tissue lie in the upper lateral quadrant, and almost 6% of the breast tissue lie in the lower medial quadrant. So that is why most of the lump or any carcinoma will arise from the upper lateral quadrant. So that is why most cancer, or you can say the most of the lumps arises in upper lateral quadrant, and the least the cancer only on very low or very less cancer or lump in lower medial quadrant. So this is a concept that you have to understand. Talk about the lymphatic drainage of the breast. So see, especially the upper medial quadrant and the lower medial quadrant, the whatever the lymph are actually present in these quadrants, they will somehow drain. Some part of them will drain into these especially lymph nodes from this both side. So these are the lymph nodes or the group of lymph nodes that are just behind, or the lateral to the sternum. So these are known as parasternal lymph nodes. So the parasternal lymph nodes are the lymph nodes just lateral or the sideways to the sternum, and they will ultimately drain the lymph coming from the upper medial and the lower medial quadrant of the breast. And whatever the lymph is present in the this, let's suppose this is the right side and this is the left side breast. So whatever the lymph that is coming into the lymph node of the, or in the parasternal lymph node of the right side and parasternal lymph node of the left side, both get intermixed. So we can say that there is a connection between the right parasternal lymph nodes and the left parasternal lymph nodes. So that is why if any cancer arises in the upper medial or lower medial quadrant of the right breast, so that can easily enter into the left breast also via the parasternal lymph nodes, as the parasternal lymph nodes of the both sides of right and left side are connected. That is why whatever the cancer present in the right side of the breast, especially in the upper medial and lower medial quadrants, can easily go into the left side of the breast as well via the parasternal lymph nodes. So now let's suppose this is a diaphragm. And below the diaphragm we have the lymphatic plexus. So let's suppose this is the lymphatic plexus. So this lymphatic plexus is known as subdiaphragmatic lymphatic plexus. So this is known as subdiaphragmatic lymphatic plexus. And this subdiaphragmatic lymphatic plexus especially carries some part of the lymph coming from the the lower medial quadrant. So whatever the lymph coming in the the lymph actually draining from the lower medial quadrant, some part of it will go into the parasternal lymph node and some part of it will go into the subdiaphragmatic lymphatic plexus. And the sublymphatic diaphragmatic plexus will ultimately drain into the abdominal lymph nodes. So now let's suppose this is a person, and this is a female, and we are watching the hands of the female. This is a neck, and this is a muscle I have shown. So these are the two breasts. I have shown you the different quadrants, and this is a muscle. So this special muscle I have shown you in this picture is actually the pectoralis minor muscle. So P minor, it means pectoralis minor muscle. And now, so you have already seen that there are group of lymph nodes, or you can say two lymph nodes. So these lymph nodes basically take the lymph from or drain the lymph from the medial quadrants, or either that is upper medial and lower medial, and there were some lymph or some lymphatic plexus present in the subdiaphragmatic region. So the lower medial quadrant also drain into some part of the lower medial quadrant also drain into the subdiaphragmatic lymphatic plexus, which ultimately drain into the abdominal lymph nodes, abdominal lymph nodes. So now let's see that below the pectoralis minor muscle there are a group of lymph nodes. So there are some group of lymph nodes in the anterior region. There are some group of lymph nodes in the basically in the posterior region, and there are some group of lymph nodes in the lateral region. So this anterior, posterior, and lateral. So this anterior region group of lymph nodes is known as pectoral group of lymph nodes. Pectoral lymph node, we can say pectoral lymph node. This posterior is known as the subscapular lymph node. The posterior is known as subscapular lymph node, and the lateral is known as humeral lymph node. Humeral lymph nodes. So there are three lymph nodes basically lying just below or lies just below to the pectoralis minor muscle. So you can see that this is the pectoralis minor muscle, and these three lymph nodes lies below to the pectoralis minor muscle. And these three, so basically these three lymph nodes just below to the pectoralis minor muscle, that is the pectoral, humeral, and subscapular, are also known as, the pectoral is known as anterior lymph node, the subscapular is known as posterior lymph node, and the humeral is known as lateral lymph node. Lateral lymph node. So in overall, these three lymph nodes are known as level 1. These three lymph nodes is known as level 1 lymph nodes. Level 1 lymph nodes. So why they are known as level 1 lymph nodes? As any as any kind of the drainage or the lymphatic drainage from the, especially in the from the upper outer quadrant and the upper lower the lower outer quadrant, upper outer quadrant and lower outer quadrant are especially drained into these three lymph nodes for the first. So initially, or in the for any lymph present over these upper outer and the lower outer are first drained into these three lymph nodes. So that's why they are known as level 1 lymph nodes. And from these lymph nodes, they are taken into the level 2 lymph node, and the level 2 lymph nodes are present behind the pectoralis minor muscle. So there are a lymph node that is known as central lymph node. So here is a two lymph nodes in the central region. There are two lymph nodes just behind the pectoralis minor muscle. One is a central lymph node, and another is a infraclavicular lymph node. Infraclavicular lymph nodes, and the central and infraclavicular lymph nodes are known as level 2. Level 2. So whatever the lymph nodes are collected in the level 1 are ultimately taken into the level 2 from these. From these three, they are taken to the level 2, and level 2 are just behind the pectoralis minor muscle. So level 1 is below to the pectoralis minor muscle, and level 2 is behind the pectoralis minor muscle. And whatever the lymph is ultimately collected into the level 2 are taken into the level 3 group of lymph nodes. The level 3 are also known as, so they are just beneath the clavicle. So they are the level 3 lymph nodes are just beneath the clavicle. They are known as, so level 3 there is a apical. So in level 3 there is a one lymph node, there is a apical lymph nodes. There is a apical lymph nodes. So this apical lymph nodes is also known as level 3. And there is a fourth level that is just above the clavicle. So the fourth lymph node is just above clavicle. So this is known as supraclavicular lymph node. Supraclavicular lymph node. So supraclavicular lymph node is basically the level 4. So this is the process by which the lymph are taken into the different levels. And if let's suppose if any tumor is present in the upper lateral or the lower lateral, the upper lateral, lower lateral quadrant of the breast. So they are first taken to the level 1, and if it is taken to only to the level 1, it means somehow there is a good prognosis, and whatever and as if the level are increased, it means the disease has get worsened, and there will be the worst prognosis as the levels will also increased. So let's quick recap. So if let's suppose this is a P minor muscle, and below to the P minor there are three lymph nodes, and these three lymph nodes are level 1. Level 1 name I have already told you, the anterior, the posterior, and the lateral. This is known as pectoral, this is known as subscapular, and this is known as humeral. And just beneath there is a two lymph nodes, that is two lymph nodes. They are central And sorry, I have already in the previous section I said you this second lymph node is the infraclavicular. No, this is not infraclavicular. This is actually interpectoral lymph node. Interpectoral lymph node. This is not infraclavicular lymph nodes. So sorry for that. Correct it. It is not infraclavicular. It is interpectoral group of lymph nodes that is just between the pectoralis major and pectoralis minor muscle. So these two lymph nodes are lies behind the pectoralis minor muscle. So these are the level 2, and above to the level pectoralis minor muscle there are one lymph node that is known as apical lymph node, and yes, this apical lymph node is also known as infraclavicular lymph node. Infraclavicular lymph node. So you should just think that here is a clavicle. So below to the clavicle there is a level 3, and above to the clavicle there is a one group of lymph node that is a supraclavicular lymph node, and this is a level 4. So there was a doctor that is known whose name was Burks. So Burks given the 4 level. So and in this 4 level 1, level 2, level 3 and level 4. So if any cancer reaches to the level 1 lymph nodes, so it means somehow there is a good prognosis. And if some cancer crosses the level 1 and reaches the level 2 lymph nodes, it means somehow there is a poor prognosis. And if it reaches the level 3 lymph node, so it indicates somehow there is a worst prognosis. So yes, this is the thing that you have to keep in mind, and this level is known as Burke's level. In the breast, we have divided the breast into the 4 quadrants, and I have already said you that 60% of the breast tissue lie in this quadrant, 12% in this, 6% in this, 12% here and 6% here. So in this way you can just easily appreciate that the most of the breast tissue of this region, so the bulk of that breast lymph is present over this, or we can say that the bulk of tissue is present in this region. That is why most of the breast of this side, most of the lymph are drained from this side, are taken into the axillary group of lymph nodes. And already I have told you all the levels. So those levels were actually on the included in the axillary group of lymph nodes. That is why most of the breast the lymphatics are actually drained into the axillary group of lymph nodes, which contains all of those we have already discussed. That is apical, that is anterior, posterior, lateral, the centrals, all were the axillary group of lymph nodes. And so somehow a very less amount from these quadrants were taken into the the parasternal, and ultimately from the axilla, all whatever taken into the axillary group of lymph nodes will ultimately go into the whatever axillary lymph nodes group of lymph nodes that takes the lymph will ultimately go into the subclavian lymph nodes. Subclavian lymphatic trunk, and from the subclavian lymphatic trunk they ultimately reach into the right and left lymphatic duct, and so they will reach in the right and left respective. If the right side there is a right lymphatic duct and the left side there is a left lymphatic duct, so right and left lymphatic duct, and ultimately from the right and left lymphatic duct they will enter into the internal jugular vein. So internal jugular vein or the subclavian vein. So yes, so this is a picture of all the draining and the lymph nodes. So thank you for watching this video.